everything we do on treatment is really based on pathophysiology. Just to remind us, what is the role of, what's a current understanding of the pathophysiology with all the multiple pathways that we now know. I always say when I did my undergrad, the pathophysiology was only 3 pathways. It was insulin resistance, it was pancreatic. What was the other one? Beta cell dysfunction resulting to reduced insulin production. And what was the third one? Was there even a third one? I don't. Yeah, I think it was that mostly. It was resistance and insulin produced adequately, and hence the treatment of diabetes was also very straightforward. It was you give metformin to address resistance, or you give insulin, or you give sulfonylureas, which were stimulating the beta cells to produce more insulin. So that was a nice time to practice diabetology because it was very straightforward. Even the guidelines were very straightforward. You started with metformin, then you increased the dose, and then it didn't work, and then you added glibenclamide, and then even the sulfonylurea was one. It was called glibenclamide. And if it didn't work, you switched to mixed insulin. There was nothing even like basal insulin. It was very hard to fail a diabetes question, really. Anyway, so it got a bit complicated, but probably better for the patient. That affects the whole of your left top corner, and there's still pancreatic beta cell dysfunction, which is really more of genetically coded for. Genetically, these people with type 2 diabetes have genes that predispose them to losing beta cells earlier in life, and so insulin secretion is lost earlier. The truth is, all of us, if we lived like Methuselah to 900 years, we would all be diabetic. I don't know how he wasn't. Because all of us, after the age of 25, we start losing beta cells. So if you live long enough, you would get diabetes. But for people with type 2 diabetes, they lose those beta cells at a faster rate than people who don't have type 2 diabetes. But now we also know that, in fact, even at the liver, it is not just the resistance. There's, yes, insulin resistance, but that the resistance does a lot of roles. It plays, it messes up with the liver function. It causes increased glucose production. We know that there's decreased glucose uptake in muscles because of resistance. There's increased lipolysis at a time when blood glucose levels are high, and you should be having the reduced breakdown of fats. And so you release more glucose. But in addition, we understand that there's a role of the brain, there's a role of the kidney, there's a role in the pancreatic islet cells, there's a role of the alpha cells. There's increased glucagon secretion in type 2 diabetes. And we now know about the incretin effect in the gut. So there's a whole lot of organs we had earlier on ignored. So in the brain, neurotransmitter dysfunction, and in particular, dopamine transmission. And that's why bromocriptine, if you look at its FDA, it's now also approved for use in type 2 diabetes. We rarely use it for that, but it's one of the agents that can be used in type 2 diabetes. In terms of a kidney, we are going to talk a lot about sodium, glucose, SGLT2 receptors. And it's because in type 2 diabetes, we know that those receptors are upregulated. And so you have excess reabsorption of glucose, which you should be losing when you're having hyperglycemia. And also, we understand the role of glucagon, increased glucagon secretion, and also the incretin effect, that there is hormones that are produced by the gut, the glucagon-like peptide and glucagon insulinopeptic hormone, which act on the pancreatic beta cells to upregulate production of insulin in response to the glucose stimulus. So if 1 millimole of glucose was going to raise your insulin production to cause your pancreas to produce, let's say, this is just, it's not true, 2 units of insulin. When you have GLP-1 in circulation, it will produce like 10 times. It will produce 20 units of insulin instead. So very, very important hormones. And therefore, you will see that as we move, these are the same areas that the classes of drugs we'll be talking about are targeting. Good old metformin is still working at reducing resistance, especially in the liver. sulfonylureas working at beta cells, trying to improve their function to release more insulin. DPP-4 inhibitors, dipeptidyl peptidase is a hormone that is produced to reduce the half-life or the duration of action of GLP-1 once it's released by the gut cells. So DPP-4 makes your GLP-1, which you're producing, lasts for much shorter, because otherwise it would overstimulate the beta cells, you'd produce too much insulin, you'd have hypoglycemia, and the body is always protecting you from hypoglycemia. So if we block the DPP-4, we inhibit it, then we allow your own GLP-1 to act longer, and that helps you produce a bit more insulin in response to meals. And like SUs which work, whether you've eaten or not, they'll stimulate insulin production. DPP-4 inhibitors will only stimulate insulin production in response to your glucose intake. We have GLP-1 receptor analogs, which have mostly been injectable, liraglutide and the like. But now we do have oral GLP-1 receptor analogs, and actually we do have it now in the country. So this is a really good space for us, because one of the key hindrances of using GLP-1 was that it's injectable. And the question was, why should I go for it instead of insulin? And then SGLT2 inhibitors, we have very many of them, and we'll be talking about the one from Cosmos today. Thiazolidinediones, pioglitazone, remember, a drug that is rarely mentioned, but you will find it's now coming back in the guidelines a bit more strongly than before. So these thiazolidinediones will work on resistance at the muscle and fat level. SGLT2 inhibitors will work at the kidney level. DPP-4 inhibitors, GLP-1, are really augmenting the gut in glucose control efforts. And then, of course, on this side, we still have good old insulin, which is still probably the most effective glycemic agent in terms of reducing glucose. So having taken you through that bit that I just highlighted so that we're on the same page, the question is, which guidelines do we follow? And we have very many guidelines. These are just but a few. We have the World Health Organization diabetes guidelines. They're not as frequently updated as the rest, so I did not really go deep into them, but we do have WHO guidelines that inform a lot of our guidelines locally. We have the American Diabetes Association Standards of Care. I talked about the AACE, which is a 2023 guideline. We're expecting 2024 later in the year. Then we have the National Institute of Health and Care Excellence, NICE guidelines, 2022, British. I think British people are still very conservative. They take a bit longer to review, so they're still on 2022. I think 2024 they'll release a new one because it's a bit outdated. But it still has a lot of very useful, they're very practical actually, and very pragmatic in how they do things. What they've put in their guidelines may apply more for us than even the ADA guidelines. And then the Kenya Diabetes Study Group led MOH guidelines, so we completed last year, and this will be released later in June. Unfortunately, I'm not at liberty to share those ones. So I'll just mention, you can look out for them. They'll be launched in June. So let's go to the AACE guideline. So I'm only going to highlight to the AACE and the ADA because I think it summarizes everything, and maybe add a sentence that comes from the NICE guideline. So the key things in the AACE guidelines, they've really changed. And can you see? I don't know where that might. Okay, not. Okay, can you read? Oh, it's too little. It's too small. Oh my, okay, I don't know how to blow it up a bit. It can't. I'll read for you anyway. This is easy. I think if you get nothing else, get these principles because they cut across all guidelines, and I'm sure there'll be the same principles that we will adapt in our guidelines. That first and foremost, lifestyle modification will always still underlies all therapy. Lifestyle modification is still the key driver of success in diabetes management. And there's not a single agent to date that has been produced by anyone that helps us control diabetes if there's no lifestyle modification. So we cannot forget and we will see a little bit of what we are talking about. 2, maintaining or achieving optimal weight is critical for diabetes control. And I think that fits a bit into lifestyle, but the reason it's now been separated in this particular guideline is that now there's pharmacotherapy for weight management that is effective. Previously, it was wishy-washy. Now we do have very effective medicine for weight management, and we also have bariatric surgery. So it cuts across, it's a whole field on its own now. Choice of antihyperglycemic therapy reflects glycemic targets. So we still are emphasizing glycemic control. I know sometimes people talk as if that's irrelevant. We will see why it's still relevant to bring down the glucose. So there's still a role for glycemic control, but in addition, we are widening that space now to look at atherosclerotic cardiovascular disease, because cardiovascular disease is the leading cause of mortality in diabetes. It is not glycemia, it's infection, it is actually MIs and heart failure that cause majority of the deaths for diabetes. And that's why it will always be central. Congestive heart failure, chronic kidney disease, overweight, obesity, and now the liver sneaks in, non-alcoholic fatty liver disease, or what we used to call NASH, non-alcoholic steatohepatitis. So this, when you're choosing the antihyperglycemic medicine, you must really consider all those complications and comorbidities of diabetes. Choice of therapy includes ease of use and access. I really love this particular guideline because of that. Previously, we talked large and assumed everything is accessible and affordable to everyone. And that's why for a long time, we've been left behind. We've really not been able to follow anyone's guideline. But when you're choosing, please make sure that whatever you're giving a patient has ease of access and also can be afforded. Optimal A1C is still less than 6.5%. However, we now have liberty to use a higher cutoff depending on the safety and what is achievable for the patient in front of you. You don't have to push everyone to below 6.5. Individualize all glycemic targets. We no longer have, that's why we say optimal, but then your target and my target would be different. Get to goal as soon as possible. So this business of seeing the patient 3 months after the first visit, in 3 months, you should be at goal. So if I'm at 10% A1C and my goal is 6.5, in 3 months, I should be at 6.5, which means initially you need to see me much more often than or frequently than before. Avoid hypoglycemia. It's as simple as that. Whatever you do, do no harm. And then continuous glucose monitoring is highly recommended to assist patients in reaching goals safely. And in many countries, they've now fully embraced that. All type 1s are on CGM, and quite a number of type 2s are also on continuous glucose monitoring. And lastly, comorbidities must be managed for comprehensive care. And we'll look at which comorbidities in particular. So if you get nothing else, please get that slide, because if you follow these principles, whatever you do, you'll get it right somehow. Oh, I have this. Yeah, so one other thing they've added, again, this is an area we all know, but haven't, okay, which one is for pointing? I didn't do the tutorial before starting, thank you. Yeah, so this is the pre-diabetes algorithm. So for the first time, we do have a pre-diabetes management algorithm. And why? Because previously we thought pre-diabetes was an innocent disease and there's nothing we could do about it. But we've had several big trials out. The diabetes prevention program studies have shown over 50% reduction in progression from pre-diabetes to diabetes if you gave intensive structured lifestyle modification. It has shown a 30% reduction in progression if you used metformin. And so for that reason, there's something we can do about it. Bariatric surgery has been used and shown to almost 100% reverse pre-diabetes. So again, there's something we can do about prediabetes. And for that reason, we have a guideline, and I'll quickly just highlight what is key. And the key thing again is to prevent progression to diabetes, prevent progression to non-alcoholic fatty liver disease, which is very common in prediabetes, and improve cardiovascular risk factors on independently, yeah? And all this you can do through weight loss, reducing weight gain, and also improving functional quality of life. And lifestyle interventions, in particular nutrition, physical activity, sleep hygiene. I'll highlight sleep hygiene. We rarely ask our patients, how long are you sleeping? How deep is your sleep? Are you dozing during the day? Because these now are very critical points in the pathophysiology of type 2 diabetes, the quality of sleep, and of course, other healthy habits. And when I talk of other healthy habits, we are talking about stress management, we are talking about alcohol use, cigarette smoking, and so on. So this is when we talk about lifestyle intervention, we are talking about intervening on each of this in a structured, measurable manner. Yeah. And then cardiovascular risk reduction, and the targets are actually similar to type 2 diabetes in terms of blood pressure reduction, LDL cholesterol interventions, all that. The targets, lipid management targets are exactly the same as type 2 diabetes. Why? Because there's 3 times higher risk of cardiovascular disease in people with pre-diabetes. I'm not talking of diabetes. Pre-diabetes already markedly increases cardiovascular risk. And then overweight and obesity, and the management of this, we now have 2 areas. If the person is overweight or obese, you can actually aim to lose 7 to 10% of their weight. I think 7 to 10% has been shown to reverse the pre-diabetes. And you can use either GLP-1 receptor analogs, you can use phentermine, you can use topiramate, extended release. And if none of that works, you can then consider bariatric surgery, especially if the obesity is at a BMI of above 35. However, if I am pre-diabetic and I have no overweight or obesity, then the goal is to treat the dysglycemia, is to treat my glucose, because metformin has a 30% chance of reversing prediabetes in me. So metformin is a main drug, but we also have a study, the IRIS study, that showed that pioglitazone can and actually did reduce to a very significant percentage progression to diabetes. There's a study that was done on acarbose also. The problem with the acarbose trial is there was a lot of dropout. So, but it still showed a positive signal. So any of these drugs can be used and can help reverse prediabetes. And so lastly is if they do get into the overt diabetes, then you now to the diabetes glycemia control. I think I'm really excited about this guideline. I'm really excited because I think this was the Minister of Health. This is where I would invest the most in diabetes prevention. If we are able to pick people with prediabetes, if we are able to design, and maybe as a researcher also, lifestyle interventions that are doable and measurable in our setup, I think this is the game changer. It would markedly reduce the number of people progressing. Okay. And then we now go to, so they divided diabetes management. They looked at it and they said, what has been the problem with all the guidelines to date? It's that initially we thought the main problem was glucose. And so all the guidelines are around lowering glucose. Yet we have clearly shown through the ACCORD trial, the advanced trial, that there's very little effect on macrovascular complications from glycemic control in diabetes. There's very little reduction in what I said causes death in diabetes, which is cardiovascular disease. So it doesn't matter whether I pump you with insulin and get your sugars down, I do not have much effect on your heart outcomes. And those are the ones that will take you to an early grave. And so the question has been, then what do we do? And in the recent few years, through the many trials that have happened, CVOT trials, it has been shown that there are particular classes of drugs that on their own independently, regardless of the effect on glucose, have an effect on cardiovascular outcomes. They reduce both use, especially MIs, they also help with heart failure improvement, and they've also been shown to actually have very positive effects on CKD. And for that reason, then it is clear that it's not just glycemia. There are other pathways within a diabetic body that lead to the major cardiovascular outcomes we are looking out for and to CKD. And it has been necessary to then retune our minds to think about diabetes as, yes, there's a path of glucose that's leading us straight to hell, but there's also the path of hypertension, there's also the path of lipids, but there are also other paths that we've not explored, and there are these particular classes of drugs that seem to address those multiple other pathways. And so why don't we divide these guidelines into different centric pathways? So if I'm looking at you just thinking of glucose, this is what I would use, the glucose algorithm, which will tell me that the main aim here, even as I look at it, is to lower your HbA1c. Yeah. So lifestyle intervention is still primary. Secondary is metformin. Again, that's why I love this. It still keeps metformin where it belongs as a second agent after lifestyle. And not necessarily in that order. You will see it's often concurrently. Now, once we are able to, if you're able to tolerate metformin to the maximum and we are on lifestyle, the next question is, what else do we need to target? What's the target, the glycemic target of this person? And in a short while, I'll show you why that's important when you're choosing the agents. So what glycemic target should we have for this person? And we've said optimal is 6.5. But who do we target 6.5? If a 40-year-old, a 48-year-old, even a 50-year-old professional came to me with type 2 diabetes, newly diagnosed, and is able to monitor their blood sugar, is able to get into an exercise program, is able to change their diet and eat a low-carb diet, then it's a kind of person I would actually target to go below 6.5. I would even target to go to the diabetes reversal, which I'll not be talking much about. But if you bring me an 83-year-old who has had diabetes, has some neuropathy, really, I would not target 6.5. I would probably target, has some pretty serious cardiovascular disease underlying. Then this is a person I would be targeting, even 8% would be good enough. Yeah, so it's different for different people. And so if this person decide based on the person in front of you what your target is. Now, also look at the person and tell me, is this person overweight, obese? If my BMI is around 32, 35, 40, then you probably don't in as my primary agent, because I'm going to add loss is a concern for me. If I am, and now I'm giving you Kenya, a truck driver, then hypoglycemia is a real concern. You don't want to give me a drug that will knock me off somewhere in Zambia. If I am a Kenyan whose taxes have just been increased and the salary reduced, the price of everything has increased, then cost is an important consideration. If I have come to you with severe hyperglycemia, which is anything above 16, then your goal is to get that glucose down very quickly before you actually now put me on drugs that will treat me long term. Yeah. So this person, everything else takes second stage here. Here you want that glucose down, and probably you'll start with insulin and then step down, or at least an SU. And if I present with more than one scenario, again, you wait. So you see how complicated it can get if you think of it in terms of, but if you think of me as a person, then it becomes easier. Because, and if you discuss with me, you'll even tell me, there's this drug which is really nice. It's called semaglutide. You can get a jab, or you can get it at 5,000 every month, and I'll tell you, hata kama ni kuishi, hapo siwezi. So let's have the discussion with the patients and try and know the costs of these drugs so that you're not putting someone on something they have to sell their shamba and they're going to be on it for the rest of their lives. Then, of course, look at the preferred. So the preferred drug in overweight obese would definitely be GLP-1 receptor analogs or SGLT2 inhibitors. In case of hypoglycemia, again, those two classes would be your primary consideration. Access cost. Now we know the cheapest drugs in our setup. Remember, they're already on metformin. So it's either thiazolidinedione, a sulfonylurea, or we don't even have glinides, so that doesn't apply here, or a DPP4 inhibitor, because the costs have come down. But for us, I think we do have good generic SGLT2 inhibitors that still would fit here, even where access and cost is an issue. Of course, if it's severe hyperglycemia, you really are limited in our setup to basal insulin or prandial insulin or sulfonylureas. And you have all these alternatives which you can also choose from, but there are concerns. In overweight, as much as possible, avoid sulfonylureas, avoid glucose, avoid insulin. Hypoglycemia, the same. Where access is an issue, avoid GLP-1 analogs and avoid the more expensive SGLT2 and so on. So this, you can walk through it right in front with the patient in front of you, and it will really guide you. I just want to emphasize why glucose control is still very key. Remember the DCCT trial, one of the oldest trials, it clearly showed that if you lowered your HbA1c, you markedly reduced, or with every increase in HbA1c, you had very significant increase in microvascular complication, and in particular retinopathy, and also in microalbuminuria and nephropathy. So by lowering A1Cs, we do save the patient quite a bit. Oh, I've gone the other way around. Yeah. Now look at this. With an increase early, if you control patients early, that's the second point I want to make. So I've caught you late, I still should bring down your glycemia, because we know clearly by bringing it down, I reduce your microvascular complications. Now, if I catch you early, you've come very early on, and I take, the reason we're saying in 3 months, I quickly bring down your A1C. If I lower your HbA1c by just marginally, look at this. Early control, if I just control you early, even with very little, from 1, 2, 3, 4, look at those in terms of years. I save you a lot of years in terms of risk of end-stage renal disease. So by reducing HbA1c, you markedly reduce or you increase the number of years the person will live without dialysis. It might reduce the income of Dr. Matthew, but I think it would help very many other people. Poor glycemic control in the first year of diagnosis leads to increased risk of microvascular and macrovascular events. Look at the microvascular, it's very dramatic. If you lower someone's HbA1c from 9 to 7, which is here, look at that drop. Over 80% reduction in their risk of microvascular complications. Yeah. Just 2. And yet many people I see say, his HbA1c is not too bad, it's 8. Look at 8, yeah, this color, 60.3%. The risk is 60.3% compared to 6.5, 20.4. So very small marginal increments in HbA1c have a huge impact on microvascular complication. And again, even for macrovascular, there's some effect. There's about a 10% effect for every 1% rise in HbA1c. And of course, even for mortality. So where I'm going, yes. And so when you're deciding which drug to choose, and again, remembering what we've just looked at, you then must have in mind, what is the drop I'm aiming for? So if I came to you with a HbA1c of 12%, and I am the first class that I described. I'm able to exercise, I'm able to get the correct diet, I'm able to understand and monitor myself. What's my target? 6.5%. So you think metformin can take me from 12 to 6.5? Can metformin take me there? So the maximum effect you can get from metformin is 2%. So you can move from 12 to 10. So why do we start every patient with metformin alone? Exactly what are we aiming to get? So have at the end in mind that the end I want, I need a drug that will drop this person by 6. The only drug that can drop anyone by 6 is insulin. But it doesn't have to be insulin alone. You could still do a biguanide. You combine with either a deep an SGLT2 inhibitor based on that profile we talked about, and do a basal insulin. And in 3 months, I can assure you, you're very likely to be at 6.5. I have enough patients who move from 13 to 6.5 if you do it right. So do not just treat. There is no, that old algorithm, please rub it from your mind. The one that used to say metformin 500 milligrams twice a day. Alafu you see after 1 month. After 1 month, the guy has wasted. He's lost 10 kilos. Then now you add to 850 BD another month, and you're just mistreating the poor guy. Hit hard, hit hard. If you have to combine 4 drugs on day one, do it. Get the sugars down, rationalize, remove some, and maintain the patient on what they need thereafter. So the most aggressive time should be the first time you see the patient. Of course, bearing in mind all the other things we've discussed. Sulfonylureas, just like biguanides, will give you up to 2%. We don't have maglitinides. Thiazolidinediones are actually pretty good drugs, and I'll highlight one of the areas they work, but again, you can get up to 1.4%. Some literature says also up to 2% drop. And then I'll jump. We still have alpha-glucosidase inhibitors, minimal, but they have a role, especially where your main problem is postprandial hyperglycemia, then you can try them. And then DPP4 inhibitors, when they're combined with biguanides, they actually increase this effect to 3.5%. So they can have a pretty good effect in combination. And SGLT2 inhibitors also, again, the good thing is you can combine them with anything, even with insulin. So you can see the maximum you expect. So for that guy, you must have insulin on board, and then now decide what else do I need, yeah? And you don't have to stay on insulin forever. You start on insulin, once they're controlled, you can actually stop, yeah. So the second algorithm was a complication-centric algorithm. This is now just looking at what we talked about. Does this person have atherosclerotic cardiovascular disease? Do they have heart failure? Do they have stroke? Do they have CKD? And hence the need to do enough investigations on the first visit, as much as can be afforded, because you want to really rule out or rule in these key things. Especially on the first visit, you really must have a UEC and a microalbumin, or at least a urinalysis, so that CKD is easy to figure out. And the other thing you must have is an ECG. If nothing else, do those two and the HbA1c, and you have quite some information to help you stratify this person, decide which phenotype are they. So if they are at high risk of atherosclerotic cardiovascular disease, then again, SGLT2 inhibitors or a GLP-1 receptor analog, which we rarely use because of cost, so it's SGLT2 inhibitors for us. If they have heart failure, again, SGLT2 inhibitors. If they've had stroke, this is the interesting one, stroke or a TIA in the past or in the recent past, then it's either GLP-1 receptor analog or pioglitazone. And this is from the IRIS trial that showed 30% reduction in restroking with pioglitazone given soon after stroke or a TIA. And this was in particular, the study was in people with pre-diabetes, but you can see they've relooked at the evidence and they think it's strong enough to actually have pioglitazone as a drug of choice in patients who've had stroke. Then CKD, of course, again, SGLT2 inhibitors or GLP-1 receptor analogs. So these drugs are taking over. They've basically pushed everything else down now, because not just because they are new, but because the evidence for them is very strong. Yeah. And of course, you then individualize, you will continue metformin, and you will also add a third and fourth drug if necessary. The key thing is deciding, are these drugs needed in this particular person, not because of glycemia, but because of the other complications of diabetes that they have. Sorry. Yes, I'll not take you through this, but I'll look for it and read it. Do not forget that diabetes does not work alone. It works with its helpers. It's an army made up of diabetes, hypertension, and dyslipidemia. And so they've actually come up with a very clear, again, algorithm to guide you in managing hypertension and very clear targets. And again, one other thing that has changed is the targets in patients who have CKD or albuminuria. We are targeting below 120 systolic and below 70 diastolic. So this is a group we are targeting, I think, the lowest blood pressures. And this is for dyslipidemia. Again, looking at the lipid profile, and the key thing you need is the LDL cholesterol, maybe the non-HDL cholesterol, and also triglycerides. Because if it's hypertriglyceridemia, the choice of drugs will be different from if what you're targeting is mostly LDL. Yeah. And I'll sum it up there for the American, that's the endocrine society, whatever it's called. I need water there. Cut me a drink. Yeah, so let's just highlight. I'll not repeat what we have covered because ADA does almost the same, but in one algorithm. But there are very interesting things that the ADA has brought out that I think we really need to see. One is, again, this is new, pretty recently new. It's 2024, but it was there in 2023. They've refined it a bit. Is a guideline for deciding whether the patient in front of you, if they don't look typically type 2, is an adult onset type 1. And remember, that's a very important decision to make. Is this person a type 2, or is this actually latent autoimmune diabetes of adulthood? Why? Because again, there's a study that came out, I think early last year, that showed that 30% of the people who develop diabetes in adulthood, and we classify them as type 2, are actually type 1s. Yeah, and of course, that wastes a lot of their time in the treatment. So the first thing is, does this person look like a type 1 or a type 2? If you have a patient, especially in our setup, diagnosed diabetes after the age of 35, but is extremely thin and has never been big, is actually even on the lower end of BMI, they're very unlikely to be a type 2. If you have a patient in front of you who has newly diagnosed diabetes, yes, they may be a bit heavy, but you have pretty significant ketones in urine, they are likely to be type 1. So there are those tidbits that will tell you this is not tying up. This does not look like a typical type 2. So if you have the resources, we don't really do this very often. Occasionally I have to do it, but most of the time we will try therapy as a type 2, but give them a very short return visit and keep an eye on them and decide, okay, this looks like type 1. So if you're able to, then you need to do islet autoantibodies. And if they're positive, it's a type 1. Treat as a type 1. If islet autoantibodies are negative, then look at the age. This person is below 35 years. It could be, you remember something we learned called monogenic diabetes, yeah? And therefore, you test C peptides. And the features of monogenic diabetes that we usually look for is siblings. If you have a family where 4 or 5 siblings all have diabetes, again, that's strange. It's likely to be monogenic, and most of them got it below 35. not likely to be type 1. HLA doesn't behave like that. So they're more likely to be MODY. And so C-peptide will tell you, because if it's MODY, they'll have high C-peptide, meaning using a lot of insulin. The problem is the work of that insulin. If it's less than 200, they're type 1. They've reduced their insulin production, so they're type 1. So the autoantibodies and the C-peptide will help you go down this path. But if they're above 35 and the classification is unclear, that this is what we do. What I was telling you is that I throw in metformin, a bit of a sulfonylurea, and we see. And if they're overweight and SGLT2, we see, and we monitor closely and responding, then okay, it's a type 2. If they don't respond at all and you have to use very many drugs, then probably type 1. So you can consider C-peptide at this stage, especially, you see, it's after a whole 3-year trial. Yeah. And if it's 200 to 600, not indeterminate, and you probably need to keep trying. If it's over 600, then it's clearly a type 2 who's making enough insulin. So I thought this was important, not necessarily something you would do, but especially this trial, if you have in mind that you're trying, I think you'll give this patient more rigorous monitoring than you would, because here, and you think maybe we will need insulin sooner than I think. So these are slides that I'll not read through, but I highlight them so that we can, I knew there'll be students here, undergrads and postgrads. The ADA has just done an excellent job. If we all did this in terms of the initial evaluation of every person with diabetes, I think would have very rich data, but I think would make very informed decisions. The first thing is the diabetes history. How long have you had it? What age of onset? And these are things to help us figure, is this type 1, type 2, MODY, etc. The family history, the personal history of complications and common comorbidities. And now in particular, remember, we are really looking at FLD, which is very common in our patients. And if you look for it, you'll be surprised. High blood pressure, macrovascular, microvascular. So you're looking out for this, all these things in the history. If there's someone who has had sudden death in the family, a stroke in the family, an MI previously, heart failure, CKD, these are things you want to get in the history. Now, I want to highlight some that we don't do. Last dental visit. Please, any patient with diabetes you see, ask them, when did you last see a dentist? Ask them to open their mouths. You'll be surprised. In fact, I think the commonest comorbidity of diabetes, it's not even hypertension, it's dental caries and periodontitis. And as long as those things are there, you will never control your sugars because it sustains a level of inflammation that drives your insulin resistance. So always insist on them seeing a dentist. Of course, the dilated eye exam and so on. So remember these things. Any other personal history of autoimmune disease, an autoimmune disease in the family. So if there's disease in the family, be very careful. You most likely are dealing with LADA and not type 2 diabetes. Then, of course, behavioral factors, eating patterns, physical activity, and I've said, remember, sleep is very important. Medication and vaccinations, there's a whole chapter in this guideline on the vaccinations that people with diabetes should get. For them, technology use is important. For us, I think the most important technology, if they have a glucometer, if they can learn how to monitor their blood sugar, becomes key. And on physical exam, again, you follow the same procedures. Key is now we should be screening for depression, for anxiety, for diabetes distress, and so on. So we look, and also for cognitive performance, especially in those who are above 6 years of age. Yeah. And then the laboratory, and I think I had highlighted this, the lipid profile, liver function tests, urine albumin creatinine ratio, thyroid, TSH, especially for type 1s, vitamin B12 if a patient has been on metformin because it can cause vitamin B12 deficiency and everything else there. And once you've done all that and you have all the information, the to assess the risk of care. We also need to do some. Previously, I know we are all taught to treat the initial diseases we are taught to treat is malaria positive. I don't need to talk to you. Meza hiyo dawa siku tatu, because that's all you need to do. You don't even need to know what you have. It doesn't work like that. And for diabetes, now there's a lot of emphasis in us actually being retrained on counseling, because you must convince me this. We must agree. And I have found myself there where I tell someone, you're going to do and blah, blah, blah. And then the patient loses the comes the damn, you've lost 10 kilos. Okay, so we are rejecting. Then the patient is like, sasa kila mtu ananiangalia wanafikiria ni dawa simezi tena, especially with the SGLT2, hii simezi tena. The same will cause depression, thinking diabetes. So goal setting is a shared activity that you must do with the patient. And then you set up the therapeutic treatment plan again together, where you agree, this is what we do about sleep, this is what we will do. You share that decision so that then they own it and it's easier to execute. And I highlighted this. I'm not going to go through all of it because it really repeats a lot. But I think I was a bit disappointed in this particular version of the ADA guideline on blood glucose control, because unlike the previous guideline, this one really almost throws away the drugs we had before, talking about GLP-1 receptor analog, GLP-1 receptor analog, everything. Either there's an option of another drug, and I understand it's for America, and that's why I think we should be careful not to copy-paste things, because all the other drugs still work. So do not forget the good drugs and go with this. But it's still excellent in that it takes us through the path of those who have complications, and it also takes us through the path of weight, those who are overweight, as the two main paths. I think the reason is because almost everyone in the US with type 2 diabetes is overweight. That's not true of our setup. Not everyone is overweight here. Yeah, but important. What I like from them is a decision cycle. So allow me to take a bit of time on this. The center now has to be the patient. And the key thing is, what is the goal of me treating this patient? And there are two main goals: prevent complications and optimize quality of life. Yeah. If we remember that, we will not forget that there is glucose, but there is also the other complications: cardiovascular disease, kidney disease. So assess the key person characteristics. What are their priorities? What is their current lifestyle? Which comorbidities they currently have? For example, if I have osteoarthritis of the knees and you're telling me to do 10,000 steps a day, of course I cannot do. So please take time to understand the patient. And again, a new addition is a social determinants of health. Where do they come from? If I'm dealing with a patient who's coming from Lodwar, and I currently have one who, again, I made a blunder of telling him, I want you to be eating green vegetables. And he's looking at me like, what are those? You know, because they don't get them in Lodwar. So please look at the social determinants of health for that patient. Look at specific factors that impact choice of treatment, including access and cost. I think for us, the biggest thing that impacts our choice of what treatment I'll take, to be honest, is cost. If I can't afford, I just can't afford, yeah? And of course, also the side effects. So like drugs that will cause weight gain, I'm already overweight, yeah. Utilize shared decision-making to create a management plan. And again, key here is the emphasis that really language has, and as healthcare workers, we need, I think we need, even in our universities, to bring in motivation interviewing as a skill, a totally new skill set that we all must invest to learn. Because for chronic conditions, you must motivate me to change. You can't force me. You can't prescribe for me. And then agree on the management plan together, implement it and follow up, provide ongoing support, whether it's using technology, using support groups, and lastly, review and agree on management plan and tweak it. So this is a cycle that we need to keep going. And I guess it's not just for diabetes, it applies to most chronic diseases. And I think in summary of that is that you need to do glycemic management, blood pressure management, lipid management, and you also need to consider agents that have added advantage for cardiovascular and kidney health. So what I picked from the NICE guidelines that I really liked was that they were very categorical that rescue therapy for symptomatic hyperglycemia, insulin, or an sulfonylurea without very many words. So if someone has blood glucose above 16, consider an SU being added, consider insulin as one of the options. And then that at every stage, diet and lifestyle have to be key, and there has to be effort to actually do that. So we are living at a time when there's a changing paradigm in treatment. Before we used to say, do diet and exercise for some time. When you finish, if it's not working, go to monotherapy. If it's not working, to drugs. And we're even told which 2 drugs. If it's not working, go to insulin. But the problem with that is that glycemic targets would not be met for a very long time. Monotherapy, we know, is not effective most of the time. Treatment fails to address multiple impairments that we've looked at in the pathophysiology. And stepwise approach tends to perpetuate failure. The more I fail, the more I give up, the more I get used to having blood glucose of 10 and think it's normal. And then the glucose toxicity, something I've not mentioned, will keep interfering with beta cell survival. So you lose them faster. The higher the glucose, the faster you lose the remaining beta cells. So we go back to Mr. X. Now this is question time. Talked enough. And I'm going to call randomly if you don't offer. Tell me what are the key things you find in Mr. X from all that discussion? What are the key things we need to take note of, Mr. X? Someone help me take this around. Mr. X? Huh? His BMI, he's obese. He's actually obese, BMI of 32. What else? Huh? What is his blood pressure? What is the class of hypertension here? Stage?
Stage is at 156/89, and you're targeting below 130/80 for it.
Below 130/80. So according to the normal classification, yeah, around stage 2 or stage 1? Stage 1. Yeah, stage 1 because it's not past 160. But for a diabetic, that's very significant hypertension. And again, I hope soon someone will take us through the new hypertension guidelines, because hypertension is again defined based on the patient in front of you. The other comorbidities, not as we used to. Anything about his HbA1c? Actually, this is classified as severe hyperglycemia. Yeah. Anything above 9 is severe. Current, no symptoms, which is good. Anything about his LDL? What's the target in diabetes? 1.9. So way above. And also he has a triglyceride that is high. But are you surprised there's a high triglyceride in this patient? Would you go out to treat this triglyceride? 2.4. This is a bit of a trick question. Not really, because he has severe hyperglycemia currently. So as long as you have severe hyperglycemia, don't attempt to treat triglycerides, control the sugars, then repeat. Most of the time it normalizes with glucose treatment. So if it doesn't, that's when you need to target the TGs. GFR. That GFR of 62. Where are the 60ers and 50ers? Okay. Stage 2. But remember, it's just one UEC we've done today. So again, once we rehydrate, because he's hyperglycemic at 16, yeah, once we rehydrate and he's okay, we'll repeat. And if it's truly there, yeah, then he's stage 2. But if it picks up, we'll know it's and just a pre-renal. Then ECG echo are normal. Urinalysis normal. Are you happy with this? I did only a urinalysis. And yet we have a GFR of 62. Is that okay? What should I have done?
UACR.
Yes, a spot urine, albumin creatinine ratio would have been more useful because this would lie to you that there's no proteinuria and maybe there's microalbuminuria. Yeah. And then, of course, we didn't manage to do an LFT on this visit. And that's what happens in our setup. Why? Because the patient comes with limited money, so you prioritize. Then some tests we pull over to the next visit, which is okay. Anything else here of note? I highlighted it. Long distance, truck driver. So, sorry? The age, is male. But what about the long distance truck driver? You really need to protect him against hypoglycemia as you treat him. Yeah, so there's a patient where all antennas are up for hypo, and you don't want to just give him insulin and see him in 3 months. Yeah, and then yeah, so that's. Oh, the guy has changed. Sorry, he's newly diagnosed. The other one was 5 years. I think that was an error. Nobody noticed. So I think, so which medication then, what treatment plan would we have for him? What treatment plan? You've really highlighted everything about him and what we need to know next visit. But with what we have this visit, we are watching out against hypoglycemia. We are watching out against further weight gain. In fact, we want him to lose. And yet, we are having severe hyperglycemia today. That's a catch. So what medication for him? And he was already on metformin, remember? Huh? Insulin. So what insulin would you choose for him? You can actually justify anything you say. So no wrong answer, just justify. Where you're it's an elephant. I'm looking at it from the front, the back, the side. Yes.
I think you said you were on metformin before.
Yes.
Okay, I think I'll add a basal insulin to it.
So you'd add a basal insulin. Very good. So for this guy being a truck driver, which basal insulin would you choose? Which basal insulin? Let me give you choices. You have NPH, you have glargine, and you have, yeah, those two. Between those two, which one would you go for?
Okay, I'm guessing here, but I'll go for NPH current.
NPH. Why? You can justify your question. Why NPH and not glargine? So NPH is cheaper.
Its availability.
Both are available now.
Okay, the cost price.
Cost, yeah. So it's cheaper in MTRH, but outside MTRH, not necessarily. Yeah.
Okay.
So cost can drive it to NPH, but actually the superior choice here would be long-acting, the glargine, because hypo, remember we're avoiding hypo. And with the NPH, it peaks. It has a really peaks that change by the day. You can't even predict when it will peak today. Yesterday, it could have peaked at 8 hours. Tomorrow, it peaks at 10 hours. The next day at 12 hours. It's a very unpredictable insulin. So for a long-distance truck driver, it's not the best insulin, and you'd probably go for a real basal, like glargine or Bitamune. Yeah? But that's one option. You could do insulin and metformin. I'm not certain that's the best choice here. It's a good option, especially if he had to go to work tomorrow. He still has to go, then that's a good option. Which is the other option? I don't want to ask Carol because I know she knows. I want students. Try, yeah.
You can give a SGL2 and GLP. SGLT2 inhibitor.
An SGLT2 inhibitor and
GLP-1 analog, yeah.
Good, especially semaglutide, which markedly brings down the A1C. But the problem with that combination, still the maximum A1C benefits you'd get from it, in addition to metformin, is about 2. And we are at 9 points. So we wouldn't really get to 6. So you see the moving pieces. Don't forget glycemia. Plus, he's a truck driver. I'm not sure he can afford a drug that's about 40,000 a month. And then there are the others. So costs would also be limitation for the GLP-1. But where cost is not an issue, it's an option if you're willing to just come down to about 7.5, 7.6. Any other option? Sulfonylurea, yes. Well, sulfonylurea is a good idea. The only thing I expect is the choice of the sulfonylurea number 1. Which one? Glibenclamide. Gliclazide, absolutely, gliclazide MR, because it has less weight gain than all the others, less hypo than the others. Hypo is still an issue. But if you choose a sulfonylurea, you'd probably want to add in 2 drugs at the same time, an SU and an SGLT2, because of weight gain. The SGLT2 would help you controlling the amount of weight that he'd end up adding here. So remember that. Any other option? Last option. There are many others. Actually, you could say anything and it would still be right if you can justify where you're coming from. And you've seen all the angles we're looking at it from. Yes? Yes, that's another good option, and especially because we have a lot of combinations of metformin and a DPP-4. So adding on, switching from plain metformin to metformin DPP-4, and then adding an SGLT2 and an SU, and then you can start dropping them. Yeah, of course, I suspect you drop starting with the SU, which is the one you want to de-escalate fastest and keep the safer ones, hypo-safer ones for longer. So I think the only thing we've not handled there is the blood pressure and the LDL. We've said we ignore the triglycerides until we bring down the glucose, then we recheck them. But the blood pressure needs to be addressed, and the LDL cholesterol also needs to be addressed. And of course, this patient also needs a lot of education, needs lifestyle modification plan, and it's all of it. It's not doing one thing today, then another tomorrow. It all needs to happen, yeah? So I think the key take home is that the principles of all the guidelines, whether it's the NICE guidelines, the ADA guidelines, the European Diabetes Study Group guidelines, the principles are applicable to us, even with our resource limited setting. The principles are applicable. Patient workup may have to be staggered. As I showed you, I was not able to do everything on day one. So what I do here is do the most critical today. Tell him next visit, you need to come with maybe 4,000. Let's do another 2. The next visit. So within the 3 months, you'll have had the whole profile. Sometimes it's hard to do the entire profile of the one because of cost. Also, the choice of drugs will differ. GLP-1 analogs are still mostly largely unavailable and the cost is prohibitive. But for SGLT2 inhibitors, we now have pretty affordable drugs. So we have very affordable drugs. Actually, I was surprised. One of my patients went to South Africa and they had to call me because unfortunately there, some of these drugs are still not there. So in Kenya, we are way ahead. When you see patients from Uganda, they have to buy these drugs from here. So we are very lucky to have good generics. Technology use. So as I said, most of the world is now moving to CGM. In fact, the main mode of monitoring diabetes is switching. It's now HbA1c accompanied by time in range. So you'll come across in literature a lot of time in range. And you want patients to be in range at least 70% of the time, meaning not in hypo and not in hyper 70% of the time. You want the time there below 4 to be reduced to about less than 4%. So you can only do those things with CGM. But we can innovate. We can do something that works for us. And what works for us, at least in MTRH, is what we call paired testing. It's a concept I would really like to introduce to you, paired testing. There's really no point of doing a fasting blood glucose for a patient every single day of their life. It's totally useless. Because if it's out of range, it's out of range. I've already known it's out of range. I'll adjust the testing. What you want to know is adjust for fasting, but at the same time adjust for postprandial blood glucose. The only way you can do that is you do, for today, Mama, on Mondays you do before breakfast and 2 hours after breakfast. Do for me before lunch and 2 hours after lunch. And on Wednesday, do before supper and 2 hours after supper. Take a break the rest of the days because she can't afford more than 6 trips in a week. So that's for a patient who is struggling. And with that, by the time you see them in 4 weeks, there's a pattern. And you can tell we are really having a problem post-lunch. And zoom in on lunch and find out, is it the diet? Is it the drug I'm giving that's not covering the lunch meal properly? Or, what else is happening at lunchtime? So if you do that, then you swing it to another 3 days and you see what's happening on a weekend, what's happening on a holiday. You'll find within 3 months, you know your patient very well, and you're actually now on the correct medication for that patient. But this every day, breakfast every day before supper, at the end of the day, it doesn't really help. Then you need to urgently develop certain skills, like I've just talked about motivational interviewing, which we really need in our. We also need diabetes educators, which we don't have. If you look at those guidelines, the key pillars of diabetes management is actually by the educators, not by the endocrinologists. Need to develop or adapt structured weight loss programs. The DPP program was wonderful. It's very hard to copy-paste in our setup. So lastly, I think I can summarize all this into this one slide, that we are moving from where we thought it was 1 treatment, then 2, then 3, and we are saying you really need combination treatment from one go for most patients, yeah? That will act on multiple pathophysiological defects. That the treatments targeting the pathogenic abnormalities should be used rather than treatments that are only targeting the HbA1c. And early treatment intensification is key. So the earlier you see the patient and the faster you bring down those glucose, and also intensify cardiovascular and renal disease protection, then the better. So early combination therapy is a strategic approach that all the guidelines agree on, despite a few differences. So thank you. Thank you for being very patient.
Hezbollah, please for Dr. Kamano. Thank you, Dr. Kamano, for an excellent presentation. At this time, I would like to harass a few people to come up front here. We'll have a panel.
And the other issue here is on in the diabetic clinic, many patients complain of lack of sleep. What are some of the approaches clinicians have been using to improve the quality of sleep, just the way you pointed out?
Thank you, Dr. Andalo. I needed water at this point. Yeah. So the reason I steered off from NASH is because it's a really wide topic. There's an entire, within the ADA guideline, There's an entire section that's just dealing with NFLD. And the screening, it's now recommended that every type 2 patient just gets screened for NFLD. The initial screening is LFTs, simple LFTs, but there's a score, there's a FIB4 score that's very simple to do. It uses the ALT, the AST, platelets, and age. And with that score, you can then tell who is at risk and may need elastography. What we do here, we tend to use more ultrasound because that's what we have. So if they have a FIB4 score that puts them at risk, we at least send for ultrasound. And if it confirms a fatty liver, then can send for further testing. In terms of management, in the guidelines is GLP-1 receptor agonists, the first option. Pioglitazone is also an option because trials have actually shown pioglitazone to be useful. So I tend to use more pioglitazone. There is literature that's coming out that seems to suggest that SGLT2 inhibitors will soon be added to the list for NAFLD, but we still await more stronger evidence. In terms of sleep, that's a big problem with patients with diabetes. But the commonest cause, you'll be amazed. The commonest, who can guess? This is a question, 50 bob, students only. 50 bob. 50 bob. Going once, going twice, gone. The commonest cause is polyuria, is that they keep waking up to go pee, and therefore they can't sleep. The minute you sort out the glycemia, you find the sleep issue is gone. So that's really the commonest. The second, of course, common cause is mobility. If especially the obese, they're used to a very sedentary lifestyle during the day, you'll find they're dozing off during the day. And so at night, they're not sleeping. But you need to really dig a bit deeper because people with diabetes are also at a higher risk of sleep apnea. And notice that by their somnolence during the day, they're snoring at night. So you need into the cause of sleep disturbance. But the truth is, majority of them will sort out hyperglycemia and they sleep. And you have anything to add?
Basically, I just want to add that there is a new terminology to NAFLD. Nowadays, it is called as MASLD. MASLD is nothing but metabolic dysfunction associated steatotic liver disease. So just the nomenclature change, but otherwise definitely FIB4 score, as Dr. Manu has told, is quite simple to calculate. And there are online calculators available. Less than 1.3, you are safe. If it is more than 2.6, then definitely you have an NAFLD and you can go ahead with transient elastography. But since it is not available in Eldoret, I don't know whether it's available. It's coming. Okay, then that's good. Otherwise, ultrasound is a simple means to go ahead. Yeah, thank you.
Questions?
Okay, I would like to understand why we hold or withdraw metformin when the GFR falls below 30 mils per minute. Then question number 2, why is it that CKD patients stage 5 who are diabetic type 2 do not require hypoglycemic agents?
Dr. Matthew can answer this question.
I think, sorry, I'm jumping to that. Please do not stop metformin. I think this question, we've discussed it before. Studies have been done. People have actually looked at this question. Patients, I think, a huge database from the UK. Patients on metformin and patients on SUs. And guess who got more lactic acidosis? Because that's the thing people worry about. It was the people on SUs. So it's not really true that a patient who is on metformin will get lactic acidosis. All you need to do is you need to really limit the doses. So once your GFR is below 30, do not exceed 5 milligrams. That's what we say. Okay? But of course, you also give your patient a sick day rule. Okay? Any condition that puts them at higher risk of lactic acidosis, they need to stop the metformin. temporarily. So one of these is when they have fever, feature of sepsis really, when they have diarrhea, nausea, vomiting, something that can put them volume depleted, then you really need to be careful about your metformin. Having said that, I see a lot of patients who are on huge doses of metformin, up to 2 grams a day. And we've not seen any of those conditions, but we've also seen patients who are on as little as a gram of metformin get heart failure, go into decompensated heart failure and get lactic acidosis. So I think if we really pay attention to some of those rules, we should be okay. Okay. But anyway, nowadays you have many options. You don't have to put your patient on metformin, but you see the beauty of metformin is the cost. The SGLT2s would be one option. The DPP4, especially something like linagliptin, would be a good option. But then again, we are advised that you get the patient in front of you and you look at their pocket, if possible, and try and give them medications that work for them and that work for their pocket. And metformin is one of those medications that really works for patients' pockets. Okay, so it's not true that we stop metformin. We just adjust the doses. I think that's the answer. Yes. Okay. And the second question was
Type 2 diabetic patient.
Yeah. Yes.
Type 2 diabetic. Okay, I would like to understand why a chronic kidney disease patient, stage 5, type 2 diabetes, require hypoglycemic.
Oh, yeah, very good question. It wasn't my lecture. Usually, a slide that shows the functions of the kidney. And one of the functions of the kidney is gluconeogenesis. That means the kidney actually participates in making glucose. The other thing that the kidney does very well is in metabolizing the drugs and actually excreting the drugs that are involved in diabetes care. Now, one of the medications that is metabolized specifically by the kidney is insulin. So as you lose your kidney function, one of the things then that you start losing is the ability to recover from hypoglycemic attacks because you don't have capacity for gluconeogenesis, but you also lose the ability to metabolize insulin. So the half-life of insulin starts going up and the half-life of some of the hypoglycemic medications go up. So patients then, you realize that a patient who used to be on 30 units total of insulin suddenly needs 50% of that. So they start needing 15. And then after a while, they start needing 25%. It's just because the insulin that you have been giving is now lasting a lot longer. The tablets that you've been giving is all working also more effectively. Okay, and then their ability to recover from hypoglycemia is limited. So that's why you tend to see when patients go into CKD, suddenly their sugar behaves. And then the day you transplant them, suddenly their sugar goes back to chaos. Okay, so it has to do with that metabolism and the ability to excrete and the ability to recover from hypoglycemic.
Any other question?
Yes, thank you so much. So my question is in regards to the patient case that we had today by Dr. Kamano. I'm just wondering, the patient is 52 years, that is almost close to retirement age. So my question was, at what point do we consider a career change or a pivot from the career? Because from my understanding, a significant occupational hazard for the patient, considering long distance drivers tend to drive throughout the night, so their sleep is inhibited. Their access to regular meals that are also the right caloric intake is also limited, and also the access to the drugs, they went over very long distances. So we consider maybe regulating the hours they're on the road, or even shifting careers towards maybe being a trainer rather than the actual driver. Yeah, so for me, I was wondering, in the discussion of lifestyle modification, at what point or what metrics should we actually look at to better advise our patients? Thank you.
Thank you. Dr. Kamano is asking me to say something so that I can justify by my being here. Let's really conclude. So in all these non-communicable diseases, there are these things we call social determinants of health and the social determinants of health-seeking behavior. People don't take jobs because they like the jobs, not necessarily, even me. Yeah, so these patients come to us with diabetes, hypertension, heart failure, chronic kidney disease, COPD. We try to give them medicine and we try to make the treatments work around their lifestyle, around the things they do. Okay? So instead of retiring them early or changing their career in a significant way, we prescribe the medications in a way that suits their daily living, the way Dr. Kamano was trying to lead us. Okay, so we need to keep him, and actually part of the rehabilitation of these people, because that's an important aspect of it. Every time you have a chronic disease, you have COPD, you have diabetes, you have hypertension, you have coronary artery disease, you have CKD. Part of the rehabilitation is to keep people going, keep people earning for themselves and for their families. That long distance driver is better off driving than going home, because that is how they get some insurance, some capacity to buy the medicine that we will prescribe. These things are expensive. Life is easy here, but when you go to the pharmacy, they ask you 7, 8, 9, 10,000. So I am not for asking them to retire earlier, for them keep going, but we choose for them medicines that facilitates their lifestyle. Dr. Kamano.
I think he's answered it better than I could have. And really what I did with this gentleman is we looked at his schedule. When do you drive? From what time to what time? If you leave Nairobi on a Monday, when will you reach Johannesburg? How many stops do you make? What time is the stops? Is it in towns where you can walk? Is it possible for you to certain foods by a cooler box, and we looked around it and came up with a full plan. He's not gone back yet, but next week he'll be on the road, and now he's more confident. So it's possible to work around what the patient, their own life, but you have to be very patient to take them through. Okay, here we can adjust. Do you think here you can adjust this? Is it possible to carry this? Is it possible to sign up for a gym in this town and that town, and then in this and this town you walk, and we will see how that works. Yeah, so that's possible. Because otherwise what we end up with is a cartoon that I forgot to show you, where a guy comes to see the doctor and the wife asks, oh, so what did the doctor say? In conclusion, the doctor said, I give up anything I have ever enjoyed and I ever enjoy for me to live. So you're left wondering, is that life worth it? Or is it better to actually just enjoy and then, yeah.
Any more questions? Yeah.
I wanted to inquire as to the progress of islet cell transplantation. And okay, thank you. I wanted to inquire as to the progress of islet cell transplantation in situations where medical management, lifestyle management just isn't working. And have there been any cases in Kenya that have been observed? Yeah, thank you.
I am not aware of any islet cell transplantation in Kenya, but it's happening elsewhere. And it's actually in the guidelines as an option for patients with type 1 diabetes specifically. The other more exciting thing than islet cell transplantation, because that has been there for some time, is currently there's actually a guideline for screening young people between the age of 8 and 12 for the antibodies, the GAD antibody, the anti-islet antibodies. And if they have more than one antibody positive, then they're at high risk for developing type 1 diabetes. And there's a drug that's just been FDA approved that teplizumab, yes, that can be given to markedly delay the onset of type 1 diabetes. So in terms of type 1 diabetes, I think it's the immune therapy that is now highest in terms of research to get up more drugs that we can use to delay its onset. But islet cell transplantation is still happening. Yeah.
My question, Dr. Koech. Today we talked about diabetic patients. So there is this case about post-transplant patients who are not diabetic. And in the course of treatment, when they are started on drugs, at some point in their life, they start using diabetic drugs. Is it the drugs that causes, is it the post-transplant drugs that causes diabetes, or the kidneys are failing again?
Thank you.
Yeah, that's a very good question. Thank you. So, so there's something we call in kidney medicine NODAT, or new onset diabetes after kidney transplantation. And this occurs in about roughly 20%. I think we're working on some research to get you local numbers, but 1 in 5 patients, that's 20% of the patients who undergo a kidney transplant, will develop new onset diabetes after transplantation, meaning they were never diabetic before the transplant, but then the diabetes comes when they get a transplant. Now, as you all know, the medications that we use for kidney transplantations are heavy, and they're heavy on the metabolic side. Their metabolic side effect profile is quite significant. Starting off in theater, we give these guys huge doses of what we call solumedrol, methylprednisone. And you know, we're giving as much as 1 gram for 3 days, up to even 5 days sometimes. And then later on, we put them on either cyclosporine or tacrolimus. So that huge doses of solumedrol, that steroid, has serious effects. The tacrolimus and cyclosporine also have very serious metabolic side effects. Nowadays, we really prefer tacrolimus as compared to cyclosporine. And tacrolimus is even worse than cyclosporine in inducing hyperglycemia. And then sometimes they get rejection. You have to give more doses of solumedrol, and things like that. So part of it is that. But there are also risk factors that have been shown to modulate that apart from the medication. So a family history of diabetes really ramps them up. People who have hepatitis C infection tend to also have a higher risk. People who have a fatty liver, people who are obese, females are more likely to get this NODAT, and so forth and so forth. So it's a multiplicity of factors, but part of it is really the medications that we give. Part of it also, and this is patients that sometimes we see, is that these guys were actually diabetic before, but it was never picked up. And the reason why they developed the kidney failure was the diabetes that was never picked up, gave them kidney failure. Now that you transplant them and the kidney is normal, plus the medications, the diabetes now becomes more apparent. So it's one of those things we are really struggling with. And it's one of the reasons why we really encourage you guys to send patients for transplantation early. You know, the longer you stay on dialysis, the more likely you are to develop infections, to need blood transfusions. And that sensitizes your immune system, making the kidney transplant a lot harder for us, making us use higher doses of Solimedrol, making us use higher doses of tacrolimus and these patients long-term on a higher metabolic risk and probably again to diabetes, and really making the chance of that transplant not work. So the more reason why we really encourage you to encourage your patients to get the transplant earlier on. Yeah.
Thank you. Yeah, last questions before we close.
So thank you. Thank you. This awesome team of led by Dr. Lagat in a cluster cast, Dr. Kamano and Dr. Patil. These are very eminent physicians in this town, and consult them whenever you have questions on general medicine and diabetes. Dr. Lagat is a cardiologist. Dr. Kamano is a diabetes specialist, and Patil is a physician previously in Medihill, but now set up in Eldoret Hospital. So thank you very much, team. So I would like to welcome the company that brought us here. Thank you, thank you. Who have been very gracious to bring all of us together. And Esmond, you know, we're really waiting for the next. No more slides. Okay, as promised, it is going to be 2 slides at most, the title slide and 1 slide to show you the medicines. So, Esmond.
So thank you very much, Dr. Kamano, for the wonderful presentation, Dr. Koech for the moderation, and all the panelists. Indeed, I won't take the least time. And throughout the presentation, I know a lot has been talked about, especially regarding the medication. And on the main slide, I'll just want to highlight a few items about Cosmos Limited. Indeed, it's a local company founded by Dr. Prakash Patel. And main highlights, I will highlight the accreditation by the European PICS and the World Health Organization. But also, we've been contracted or we've been certified by the USA. And also, we are market leaders from 2017. Cosmos is #1 in Kenya and across East Africa. And in the past, we've also been licensed manufacturers on behalf of GSK and Boehringer Ingelheim. So this is just part of a plant on Rango Road, Lunga Lunga industrial area. And the main thing was that for medicine to be available to patients when needed and also affordably. We have over 300 registered products, and Cosmos is an employer of over 500 Kenyans. So it impacts largely on the economy of Kenya and on many families. So it's as I mentioned, over 300 registered formulations, and we are now in operation in over 13 countries in Africa. As earlier highlighted, we believe in quality medicine, but also competitively priced. I'll go straight to the main highlight of today and introduce the latest kid on the block. That's our glycid met. We are calling it the novel combination in type 2 diabetes. As we've seen, we have so much need for quality medication and also competitively priced. So glycid has a wide range from glycid plain, which is glycid, the plain dapagliflozin, available in 5 and 10 milligram. Then they have the combination with sitagliptin, glycid plus, and now we have glycid met, which now combines metformin, 500 mg and 1 gram. So it's a 500, 1 gram, and we've indeed seen the role of metformin as a basic or gold standard in type 2 diabetes management. This is the patients we have. There are 5 of them, the 5 and 10 plain, the glycid plus, and of course glycid met. And indeed, we are looking at now having the whole range in the market, and we can assure you this will be available. As earlier mentioned, we may have almost all the preparations that were highlighted for your diabetic patient, from the sulfonylurea to the PP4 inhibitors, and we have from glucoel, these are vidagliptin, and the combination with metformin. Then we have the metformin on its own, the plain 501 gram, then the extended release. We also have diagluc, these are the best SUs. So in those products, I'd like to be very brief on this. We have our DICARD for the sacubitril valsartan combination for the management of patients with chronic heart failure with reduced ejection fraction, available in preparations, the 50 milligrams and the 100 milligrams. Moving on, we also have a product in the management of heart failure or edema with heart failure. This is our Tubina, furosemide 10 and 20 milligrams, readily available in the market. And again, in Kenya, we had the first rivaroxaban branded generic, that's our Hatiz. Indeed, as I mentioned earlier, we don't compromise on quality. Quality is high on our list, and we have a bioequivalent study with the originator. This document is available, and it's been found that it's almost 90% bioequivalent to the originator. So these are the preparations we have. The Hatiz 10, 15, and 20 milligrams, already available in the market. And as highlighted in hypertension management, equally we have a wide range of preparations. They could not fit on this slide. But mostly we have Telmicos, these are telmisartan combination with amlodipine and hydrochlorothiazide, that's Telmicos AMH. But we also have Vidol, Carvedilol, losartan potassium, Caditan, and also enteric-coated aspirin, and many more others. Equally, we have lipid-lowering agents like our Lipecos and Avastatin, all available in the market. And most of these products are even currently approved and available at MTRH and other major facilities across the country. So indeed, at Cosmos, we believe in accessibility, high quality, safe and effective medicine. And definitely, as highlighted throughout the presentation, cost is a big factor because it will definitely impact on the compliance of the patient. So as a responsible pharma company, we also believe in, when there's an adverse event, we want to hear from you. So in case of any issue with our medication, we have this available on our website. So at any time, you can reach out to us because we don't want to have any issues that are not addressed. So thank you very much. I've kept the Sam.
Yes, you've tried. Thank you. Betty Sirera is somewhere here. Do you want to come up front or you want to send me? Oh, okay. So as you all know, this event was courtesy of the local North Rift branch of Kenya Association of Physicians. By coincidence, I happen to be the chairman, and Betty, please stand up. Betty is our Secretary General who organizes us. And then is Daisy around? Daisy is the treasurer. Daisy, do you want to stand up in a stool? You see, we can't see you. So Betty is our treasurer. And then there's a host of council members here. Dr. Kamano is one of them. Dr. Njiro? Dr. Njiro? Simama. We can't see you. Yes, Dr. Njiro is one of the council members. Dr. Busakala is also one of the council members. Is he here? And then Dr. Odwar is also a council member. Dr. Odwar, please stand up as well. Dr. Odwar is a council member and immediate past chairman of the branch. So we encourage all physicians to subscribe and be members of KP, but we are open also to other cadres, including registrars. It also includes medical students. We have a category for that. And we also invite any other interested persons, including clinical officers and other people. You can join us. The aim really is to improve the physician practice, the practice of medicine, you know, in the country and in Eldoret in particular. So join us. I think in March, is it March 6th? March 6th. Is it 6th? 6th. March 6th, which is a Wednesday, 7th Thursday, 8th Friday, and then 9th. We have our annual conference of the Kenya Association of Physicians. All of you are welcome to join us. And the theme of the conference is harnessing a bit, you see, harnessing something. Wow, forgive me, I have too many things in my head, but yes, from promise to practice. So it's a mouthful, but in short, it's about patient-centered care. What Dr. Kamano was talking about, you have two patients, one you give SGLT2, another you give metformin. It's patient-centered. You look at the patient in front of you and you tailor their treatment according to their circumstances, including their medical circumstances and their social circumstances, their financial circumstances. So you are welcome for that conference in March. And then tomorrow, Dr. Lagat and Dr. Kwanalo will be hosting us again for another CME where we'll be talking about dabigatran. Dabigatran, as you all know, is an anticoagulant useful in DVTs and pulmonary embolism. So they're going to talk about that. I think Dr. Kwanalo is the presenter and Dr. Lagat will be moderating that session. So you're welcome. I believe the venue is here, but venue is here? Yeah. So you're welcome. Welcome again. Now for the doctors and dentists in the meeting, we need your, more importantly, your license number. The A11,000, A2,000, please give us that number. We can process your CPD. Sometimes we have is because we are seeing lists, but we are not seeing the board numbers. And we process it directly onto your portal. So please make sure before you leave, there's a list going around. Betty, is a list with, where is it? It's somewhere around, okay. So the list is somewhere around. Please make sure you put your name so that we can process your CPD points. I think that's all for announcements from our side, unless there are any other announcements that I've forgotten. Okay, Esmond, your announcement? Huh? There's no announcement from you. What are you saying? No, you mean we came all the way here? Come. Okay.
Thank you, Daktari. As Cosmos, we appreciate your patience and presence to be here this evening. I didn't mention my name. My name is Vincent Marigi. I'm the National Sales Manager at Cosmos. So we appreciate so much your presence and being keen to attend this event. We don't take it for granted for you sparing your time to be here. And most importantly, being a full house. Huh? I think it's a first one for a while we've had. And seeing the attendance encourages us more and more to have such sessions in future. So we'll have dinner. It will be served just karibuni sana and feel welcome and enjoy the dinner. Thank you.
Welcome, welcome. Yes,